It's really a pleasure to be here and to share our knowledge about the management of the obesity epidemic in patients with increased cardiovascular risk. I want to underline that obesity is a disease recognized by the Mondial Society of Health. So obesity is really a disease, and I do agree with what I heard before. This is my disclosure. I start from diabetes. Also, diabetes is, without asymptomatic disease, and diabetes is a cardiovascular disease, and the epidemiology of diabetes is really important. We see we will have 600 million patients with diabetes in the next year. What the matter with obesity? Diabetes and obesity are really linked. 90% of people with diabetes are overweight or are with obesity. And the presence of obesity in type 2 diabetes could worsen all the outcomes, all the complications of diabetes as really worse with the presence of obesity or overweight. So our scientific society in 2022, the consensus on the weight reduction as a targeted intervention is really important, and also the colleague of the ESC in 2023 showed that it's important to reducing weight in patients with type 2 diabetes with or without cardiovascular disease. And you see on the second line that glucose-lowering medication with effect on weight loss, so GLP-1 receptor agonist, for instance, should be considered in patients with overweight or obesity to reduce weight. It is really well known, and we have seen before, the epidemiological link between diabetes, obesity, and cardiovascular disease. You see the percentage, if there is obesity, if there is diabetes, how is important the presence of cardiovascular disease too. Obesity is really a risk factor for cardiovascular disease. This is the pooled data from the Nurse Health Study, and you see how is important the presence of obesity in developing cardiovascular disease and the presence of severe obesity. So the degree of obesity is really important to develop cardiovascular disease. The severe obesity more than 35 BMI is linked to a major presence of events and also of mortality for cardiovascular disease. Moreover, we know that obesity is an increased risk factor also without the presence of metabolic abnormalities. So we can consider nowadays obesity a real disease, and a real disease linked to cardiovascular disease, also to the metabolic problem. Why? Because there are multiple mechanisms. We know that the presence of obesity links to visceral fat mass, to producing of adipokines, so inflammation, to production of pro-inflammatory cytokines. And then in the other side of the slide, you can see that the presence of obesity is linked to the well-known risk factor we have studied in the university, we have studied in all our life, and the presence of obesity is always linked with dyslipidemia, hyperglycemia, hypertension, sleep apnea syndrome. All these features bring the patient with a high risk of cardiovascular disease and mortality for cardiovascular disease. And this about the epidemiological presence of obesity in the world. We know that there are 600 million people living with obesity in the world nowadays, and in the future we will have 1 billion people with obesity in 2030, so not tomorrow, but I mean very close to. So it's really a big problem. Why? Because there are many pathways that can lead to obesity. There are biological factor, genetic factor, physiological factor, and a lot of problem linked to obesity. And what we have seen before, obesity is not only linked to the cardiovascular disease, but also to the metabolic disease, to the kidney disease. And this is what it's well-known cardiovascular kidney metabolic syndrome. Well, according to me and to some colleague of mine, the name of this syndrome should be metabolic cardiovascular kidney syndrome, because the first stage of this metabolic problem is the presence of the excess of dysfunctional adipose tissue that bring all the other problem along the way of the history of life of this kind of patient. We have also good news. We know that if you if we can lowering by 10% or more body mass index and body weight, we have the possibility to reduce all the composite cardiovascular endpoint risk reduction. So we have a mission, okay? We need to reduce the body weight in our patient because we have the possibility to reduce to 20% the presence of cardiovascular death, myocardial infarction, stroke, and also hospitalization for angina. This is the origin trial. Well, we have seen before that we have a lot of possibility. We have to induce diet, physical activity. That is very difficult in a normal clinical practice to obtain some results, really good results with diet and physical activity. We have also the bariatric surgery. It's not the topic of my speech, but bariatric surgery is very effective on obesity, of course. And you have, of course, the medication to reduce body weight and to reduce body mass index. And in the step 2 study we have seen before, semaglutide 2.4 milligram weekly can reduce by 10% body weight in obese and overweight patient. And it is very important to think about GLP-1 receptor agonists because we have a lot of evidence in the strong literature that using GLP-1 receptor agonists in patients with diabetes, so now the first slide, people with diabetes have a strong benefit with the treatment of GLP-1 receptor agonists on MACE, cardiovascular death, all-cause mortality, fatal or non-fatal stroke, and for the cardiological community, I think is important, heart failure. And you see also the composite renal endpoint. These are the effects we know very well, we well know that the effect of GLP-1 receptor agonist or inflammation or atherosclerotic disease, they are very important. And now the SELECT trial, we have participated to this trial in Milan, and we have treated patients with overweight and obesity. It's important to think that the patient in this trial, well, with BMI more than 27, so with overweight and obesity, and the first endpoint was linked to the MACE, so all the composite endpoint on cardiovascular disease, and we have seen that the results are very, very important, less than 20%. The results were independent for the weight loss. So semaglutide 2.4 in this patient act independently for the weight loss in this treated patient. We have good results also in the heart failure with semaglutide. We know that SGLT2, they are very effective. Okay, also semaglutide 2.5% is very effective on the symptoms and on the biometric effect of HF. And these are the data very well known. We have also tirzepatide, quite new now. We have talked before, and tirzepatide is a co-agonist of 2 pharmacological targets with a very good effect on cardiovascular risk factor, BMI, HbA1c, systolic and diastolic pressure. And this is the effect on the body weight. You saw in the Salmon study, in the Salmon 1 study, we have the effect of lowering body mass index more than 20%. We have also the possibility to use oral drug because also oral semaglutide have the study in lowering body mass index at the dosage of 50 milligrams daily. And the results are very important and very effective in the reduced body weight, more than 50% in the reducing body weight and also reducing cardiometabolic endpoint in a good time, a good way of time. These are the glycemic status. And just coming to the end, it is important to remember that we have also the possibility and the data that semaglutide, 1 milligram in this case weekly, could have good effect, beautiful effect, also of the composite renal endpoint with the reduction of the 24% of the renal endpoint. So, coming from the last slide, the possibility to treat the metabolic, cardiovascular, kidney disease are really important today. Thank you.